Imagine losing the ability to move or feel your arm after a sudden accident. That's what happens in brachial plexus injury, one of the most devastating nerve injuries affecting the upper limb. The brachial plexus is a complex network of nerves originating from the spinal cord segments C5 to T1, controlling movement and sensation in the shoulder, arm, and hand. When this network is torn, stretched, or compressed, the result can be weakness, numbness, or even paralysis. In adults, most cases arise from high-energy trauma, especially motorcycle accidents or falls where the shoulder is forcefully separated from the neck. The typical patient is a young male in his 20s, a productive age group suddenly struck by disability. In newborns, the same injury may occur during difficult childbirth, and this is known as neonatal brachial plexus injury. Clinically, injuries are grouped into upper plexus, which is C5 and C6, and this leads to Erb's palsy, where the shoulder and elbow movement are lost, but hand function remains. Then the lower plexus, which is C8 to T1, known as Klumpke's palsy, affecting hand and wrist control. And then the worst is complete plexus injury. This is from C5 all the way to T1, and this results in a limp, insensate arm, sometimes with Horner's syndrome, which is drooping of the eyelid and a small pupil. Diagnosis starts with a careful history. The mechanism of injury often tells the story. A detailed neurologic examination maps out which muscles are weak and which sensations are lost. Electrophysiologic tests such as EMGs help determine whether the nerve is merely stretched, which is called a neuropraxia, or completely torn, which is known as neurotemesis. Imaging plays a key role. An MRI and CT myelography visualize the roots and detect avulsions or pseudomeningocele. But remember, when it's the MRI, it must be MR neurography, which is now the gold standard, offering exquisite detail of the brachial plexus anatomy. Treatment depends on the type and the timing of the injury. For mild injuries, these may recover with conservative management, which includes physiotherapy, pain control, splinting, and neurotropic medications like B vitamins and acetylcholine. For severe or complete injuries, these will need microsurgical repair, ideally within 3 to 6 months, before muscles lose their ability to respond. Surgeons may use nerve grafts, such as a sural nerve transfer, nerve transfers, for example, spinal accessory nerve to the suprascapular nerve to restore shoulder movement, or free functional muscle transfers, like transplanting a gracilis muscle to recreate elbow flexion. Rehabilitation begins immediately and continues long after surgery. It includes motor re-education through guided exercises and occupational therapy, sensory re-education, even using mirror therapy to retrain the brain's perception, electrical and magnetic stimulation to encourage nerve regrowth, acupuncture and psychosocial support, which reduce pain and boost motivation. Beyond the physical injury lies a deep emotional struggle. Many patients face depression, financial strain, and social withdrawal. Integrating mental health counseling and family support into rehabilitation greatly improves long-term outcomes. In young, motivated patients, recovery can be remarkable, especially when care is timely and coordinated between neurosurgeons, orthopedic surgeons, plastic surgeons, psychiatrists, and psychologists. Brachial plexus injury is not just a surgical problem. It's a multidisciplinary challenge that tests patience, precision, and perseverance. Early diagnosis, timely referral, and continuous rehabilitation can mean the difference between lifelong paralysis and meaningful recovery. For clinicians and students alike, the key takeaway is time is nerve. For the public, early medical attention saves movement and hope. Thank you for listening and have a blessed day.